Hello again, I'm Dr. DrDomPimenta, and on behalf of the Modern Society Initiative, I thought we'd just have another look at another Ivor Cummins video that he's just put up, a 2-minute UK Outlook Explained, debunked. So we'll watch it and then we'll go through some slides as we go.
For you UK guys to share widely to your politicians and influencers and business people. So the UK second wave outlook. Well, let's take 2 minutes to explain it. So first we're going to look at the epidemic curves for UK, Ireland, Sweden as compares, all very similar, classic science, right? And the epidemic ended back around here. So 12,000 PCR tests a day back in April, and now it's up to 250,000 PCR tests a day. That's a 20 times increase. And we've explained before about the case-demic and the PCR problems with false positives.
Okay, so that's a great point to stop. So he puts up this graph, but obviously the data is available in the actual form from the coronavirus dashboard. So the first thing to say is he's broadly correct, but the numbers are not quite as he puts forward. So in the beginning of April, we did about 28,000 PCR tests, towards the end of April, and that was pretty steady over August, and then we had a more increased ramp between August and October, and we did 164,000 odd tests on the 1st of August and 265,000 tests on the 1st of October. So the first thing to say is this increased period here, which is the important period where cases are now rising, there was a 60% increase in testing. So we'll come back to that. The second thing he says is he talks all about false positives, and I think this has gone around the houses quite a lot, so it's quite important to talk about. So the first thing to say is the false positive rate is this calculation here. So when you have any test, your population is either people who have the disease or don't have the disease, and the test itself can give you a positive or negative result, which creates this matrix which is called a confusion matrix, understandably. So if you get a positive test and you have the disease, you're a true positive. If you get a negative test and you don't have the disease, you're a true negative. And then if you have the disease but you test negative, you're a false negative. And if you don't have the disease but you test positive, you're a false positive. And the false positive rate is this side of the equation, so it's the number of false positives as a total of everybody who haven't had the disease. So if you take a group of 100 people and nobody has the disease and 10 people test positive, then your false positive rate will be 10%. But equally, if you take a group of people where you don't have any true negatives, so if 100 people have the disease, all of your positives will be true positives. You can't have any false positives. So it's very much determined on how the actual underlying number of true disease present or disease absent people there are. Now this is really important because when you test somebody randomly on the street, so say I was walking down the street and someone just stuck a PCR swab up my nose, what is the chance that I have coronavirus in that circumstance? Pretty low. But equally, if I have symptoms and say my wife has had a positive coronavirus test and then I go and get tested myself, what is the chance that I have coronavirus in that circumstance? And much, much higher. And that's called the pre-test probability. Now, the problem with a lot of the articles lately is they've all decided that the pre-test probability is the same as the general population, which is not correct. The other way that we can disprove this false positive being particularly high, so the number that we've all been talking about is this number 0.8%. So if we look at the number of tests actually done on the 1st of August, it was 165,000 PCR tests. Now, in order to get the highest number of false positives, we have to then assume that everybody in that cohort did not have coronavirus, so all of them, the disease was absent. And in that circumstance, the highest number of false positives as we can possibly get is 1,317. Now if you look at what actually happened on that day, 165,000 tests were done, but actually the number of positives was 544. So the one thing that you cannot have, if you look along this column, your true positives and your false positives have to add up to no more than your total positive results. So you cannot have more false positives than total positives. So if your total positives are 544, you cannot have 1300 false positives. So this means the maximum false positive rate, again, if we assume that everybody is negative, which is very unlikely because these are, again, indicated tests, the maximum is 0.3%. So it is significant and certainly something that we need to take account of. The last thing to say is in pillar 1, we do 2 swabs. We stick one up the nose and one back down the throat for most centres, which means that you actually have to do this whole thing twice. And if you do something twice, in order to get false positive, you need to get it on the first test and the second test, which means the chance of that happening in 2 separate occasions is 0.3% of 0.3%, which is 0.0064%, which is much more accurate. Therefore, a good way around this would be to repeat the tests if we're worried about false positives, and certainly when we screen patients, that's definitely something that we should be doing. But the point to take away here is that the false positives doesn't really explain what's going on. And the third reason it doesn't explain what's going on is because if we look at this, so if we go back to our same area between the 1st of August and the 1st of October, we saw 544 cases then and 6,968 cases on the day just gone, 2nd of October. And that's 1,180% increase in the number of cases. So if we go back to our original example, if we've seen a 60% increase in testing, we should be seeing a 60% increase in, if the argument is that's false positives, a 60% increase in false positives. But we see nearly 12 times more than that. And that simply cannot be explained by an increase in the false positive tests. So this argument that this is, a case-demic which is being driven by false positives and other PCR testing, it just doesn't add up when you actually look at the number of cases. And similarly, we talk about impact, so we can actually look more, at the actual number of COVID deaths. So the 7-day average on the 30th of August was only 7 deaths. And the 7-day average on the end of September, the days just gone, was 47 deaths. And that's an increase of nearly 600%. Again, testing has only increased by 60%, cases have increased by 1,200%, and deaths have increased by 600%. So again, we're seeing real-world impact. So to dismiss these as not real cases, again, is inaccurate. And lastly, we can also look at the numbers of mechanically ventilated patients for COVID. Now, speaking from personal experience, a diagnosis of COVID in a mechanically ventilated patient is very obvious. They have very specific changes in their bloods and changes in their CT. So it'd be very unlikely that this is in any way a sort of a big mass misdiagnosis, which is one of the other ideas that Ivor seems to have. And again, we can look, beginning of September, the 7-day average was 73 mechanically ventilated patients and had been broadly stable before that. And then the week just gone, the 7-day average is now 341. So in a shorter period, less than a month, we've seen a 362% increase in the number of patients going into intensive care. It's also important to remember that 341 mechanically ventilated beds that we otherwise could have used is pretty significant. So the UK has about 4,000 intensive care beds total. And at any given time is running at about 85 to 90% capacity. And we use intensive care beds for emergencies, but also for operations. So if you have a major operation, you need recovery, you generally will come to an intensive care bed, especially if the recovery is complicated. So using up our spare capacity nearly instantly is very bad news, because we will have to, in the next stage, if we use all the intensive care beds, we'll start having to reopen beds, and that means redeploying staff, and that will mean cancelling more elective work, which again has a big impact on the NHS. So this again is a big impact. Let's go back and see what he says.
Now we'll look at what they're calling cases, but you'll know from earlier videos that these are PCR positives, and they are not proper cases by any sense of the word.
So again, that's a pretty pejorative statement, which doesn't really back up any of the evidence. We can actually look as well at the number of cases that are testing positive. So if we were to decide that these were all false positives, or these were all fragments of PCR, then in theory, if the epidemic is over, as Ivor keeps telling us, then we shouldn't really be seeing increased in the positivity. It should be a static background rate. But if we look across the last 12 weeks, we can see the positivity has gone from around 1% in the middle of the summer and now up to about 7% in the community testing. And in Pillar 1, it's gone from 0.05-ish% up to 1%. So both of these have considerably increased. Sorry, up to 2.5%. So both of these have considerably increased, which again doesn't fit with this theory that these are just spurious results.
Mostly asymptomatic, but 700 back in early July and 7,100 now. So if you didn't understand case-demics, it'd be really worrying.
I don't think that we should use the term case-demic. It's a term that, as far as I can tell, Ivor made up.
Now we're going to take away and show what the impact of all of these cases rising so much has been. And you can see here the UK in blue. It's almost nothing in a sense. It's less than 1 person per million per day with SARS-CoV-2 on board.
So again, I find that slightly pejorative, and that's speaking from personal experience. If we go back to the number of deaths, I mean, we're talking about 50 to 60 people dying every single day of what is an avoidable and preventable disease. So to say this is almost nothing and there's no impact, the graphs that we'd often see, so if you look back at this graph, we see a big spike of deaths here and a smaller spike of deaths here, and that is reflective. Obviously this was a major chaotic and destructive event. If we adjust the number of tests, so in the middle of spring we could only do about 11,000 tests, and the estimate were we were missing about 10 times the number of cases that there actually were. But what we can see is that if we take the number of tests that we've got today and imagine that we have the same capacity, so we could do 160,000, 200,000 tests a day in the middle of the pandemic, what would the case numbers look like? And if we just apply the ratio, well, we look, and that's in line with estimates at the time, cases over 100%, 100,000, in spring, which closely correlated with the number of daily deaths. So there's 1,000 daily deaths at the peak, and you can see all the way through that the case testing and the deaths were linked together. And once more, we're seeing a rise in case numbers and a rise in deaths. The reason that we don't see this impact is because the testing numbers and the deaths numbers were so drastically different. Obviously, there's been real change in how deaths are counted or recorded, or not significant, but the testing has obviously been a dramatic change. So it's confusing to look at those graphs and say there's no impact and we shouldn't worry about it, when you can see that week on week we're seeing a doubling in deaths, and that is very worrying indeed, even if the impact is not as great as spring.
We'll project out and say, what could we expect in the coming months? Like a normal winter? Or something like this? Well, this is what's being bandied about by characters like this.
So there was a graph put up by Witty and Balance which was trying to explain exponential growth. And actually, if you look at this graph here, that's exactly what you're seeing. Week on week, cases are doubling, as nearly 600% increase across 3 weeks. If you look at the mechanical ventilation beds, again, you're seeing a doubling nearly week on week of people in mechanical ventilated beds. So this idea that the exponential growth is not part of the virus is something that we have known for a very long time. The reason that potentially cases aren't rising as quickly and deaths aren't rising as quickly as they were in the spring is because people are still taking very considerable social distancing measures. So the first thing is, let's look at the mobility data. So this is mobility data taken from mobile phone data. We can see in this springtime that there was a big drop in retail, recreation, transit stations and workplaces all the way down to here. And a big rise in the number of people staying at home as opposed to baseline, so about 25%. You can also see that number never really came back to normal. So about 10%, 20% of people are still doing the same thing. And similarly, workplaces, people are still working from home in about 30% of the population. Equally, this is an Ipsos Mori poll from a few weeks ago, trying to gauge what people still thought about the threat level of coronavirus, and about 30% of people think it's still a severe personal threat to themselves. And this is probably reflected in the data of the patients who are actually now being recorded as positive. So if you look at this graph, this is from the surveillance data of coronavirus, and this is everybody tested under pillar 1 and pillar 2 from the beginning of the pandemic. And you see the distribution was fairly uniform, but lots of over 80s caught it at the beginning. Now during the summer this drastically changed, and we saw a big spike in the younger group, in the 20-29, 30-39 group, much less in the older group, and even more so in the latest case numbers, that this is a big spike in the 20-29 and 30-39 year olds. However, this has now changed, and we're now seeing more cases in older patients, which is why we're seeing this slow reflected more severe illness in our hospitals. But again, we go into Spain and France, who have taken measures to reduce the cases down again, and we shouldn't worry about it. I suppose my main gripe with a lot of this stuff is it doesn't really reflect the data, and it casts everything in a sort of quite defamatory way, really, to the actual data, the actual doctors looking after actual patients, the actual scientists who are actually making the decisions, and either sort of sitting on the sidelines, drawing lines on graphs and making some pretty dangerous statements that aren't really backed up. And the reason that they're dangerous is that they breed complacency, and the only thing that we have to avoid further increases in COVID deaths is public behaviour. So although it might generate a lot of likes and a lot of clicks, unfortunately it is rubbish, and should be treated as such. I'm Dr. DrDomPimenta. This was another video for the Modern Society Initiative. Do give us a subscribe and check out the website on modernsociety.initiative.org.